So, Dr. Ranjit, we have it's a great pleasure for us in USPed to have you in this morning in Latin America, probably an afternoon in India, I think.
It's 8 p.m.
8 p.m. Wow.
PM. Yeah.
It's a lot of
so 8.5 hours.
Wow,
yeah.
Of course. So, and as Javier was saying, Javier Ponce is the director of the group, president of the Latin American group for POCUS, pediatric POCUS. He was just introducing you and giving you thanks for being in our Saturday of POCUS today. We call it Saturday of POCUS Saturday, we call it. And especially pediatric POCUS Saturday. And he was just saying how grateful he is that you accept his invitation to participate today. So without further talking and without further introduction, in our Saturday of POCUS, we have the great pleasure to have Suchitra Ranjit, an MD, CCM, the head of pediatric ICU of Apollo Children's Hospital in Chennai, India. Did I say correctly?
Yes.
Yeah. She is gonna present a presentation of POCUS in pediatric septic shock, and we're going to listen this, which I consider ahead is a masterclass. We follow Dr. Ranjit's papers and researches and presentations around the world, and once again, I'm gonna repeat it again. It's a great pleasure for us. So I'm gonna leave you with the presentation, Dr. Ranjit, and after the presentation, we're gonna discuss some topics, some probably questions from the audience. The audience always have some questions, but only after you finish it. Without further introduction, you have the time for the presentation. Thank you.
Okay. Thank you very much for inviting me once again. It's a pleasure to be with the Latin American ultrasound POCUS group, and I hope I can do justice to this invite. Over the next 30 minutes, I'm going to be talking on POCUS in pediatric septic shock. Just trying to minimize. So certainly, people who, once you get used to doing POCUS in shock, then it's hard to manage patients without POCUS. And it certainly gives a lot of useful information to the clinical exam. And my talk would be in two parts. Since most people listening, I presume have got some basic information, basic knowledge about POCUS. I'm just going to go to the basics very quickly and go into a little more of a deep dive for the most time of my talk. So I'm sure most of you would be using POCUS and ultrasound for heart function, IVC, and lung profile. And this is an article that my colleague, Dr. Rajeshwari, and I recently published, where we called it best fit. So it was really basic echocardiography in shock therapy for fluid and inotrope titration. And here, the best fit really rules out tamponade, looks at heart function, the IVC, the lung profile, whether it is wet or dry, and then monitors the response to therapy. So the first level POCUS of best fit in sepsis, it's really an extension of the clinical exam. So much like we assess the heart when we see a child with shock, we assess the heart for a gallop, we listen to the lungs for crackles, and look if there's any changes in the liver span. Similarly, the POCUS exam, a quick exam focusing on the heart, lung, and IVC, gives us additional advanced information over and above clinical examination and can really guide treatment. So quickly about cardiac performance in sepsis. So while we can say whether the heart is hypercontractile or dysfunctional, it's not like it's something that we've discovered more and more. It's not like a child with viral myocarditis or just say a VSD. It's a one-time exam and there's a VSD and that's it. Or there's a viral myocarditis, poor cardiac function, and that's it. In sepsis, the cardiac performance is linked to intrinsic systolic contractility and diastolic function, but a major influence is provided by the preload, and the maximum influence is by afterload. I'm going to give a little more explanation about this. I'm sure many of you will be aware. So preload can be altered. It means how much of blood is returning to the heart, and afterload, what is a resistance to what is opposing cardiac function. So the most simplistic way to look at it is if you have clear lungs, so it's air-filled lungs, a collapsing IVC and good function, and maybe some history of decreased intake, you would consider giving fluid bolus, and you'd probably be right, and the child will probably improve. Whereas if the lungs are wet with a lot of B lines, the IVC is full, and the heart is dilated, you might hesitate to give fluids and reach for inotropes in the first instance. A patient who's got dry lungs, a normalish IVC, and very good heart function, you'd go for pressors, but I'd like to emphasize that this profile and the hypovolemia profile, excuse me, can look very similar. So you cannot only make a decision based on the POCUS, you will have to see the clinical features. So if this patient is more likely to have cold extremities and narrow pulse pressure, if there's majorly a hypovolemic profile, whereas a patient who's got hyperdynamic profile and would have wide pulse pressures. So even for the same POCUS appearance, you would need some information for the clinical examination to finalize your treatment plan. Let's a little bit talk about fluid responsiveness versus fluid tolerance. So the Surviving Sepsis campaign advocates if you do have an ICU, you can give 10 to 20 ml per kg per bolus, up to 40 to 60, titrated till clinical markers of cardiac output improve, and discontinued if signs of fluid overload develop. So this is what is advocated in the Surviving Sepsis, right? So most of us will be familiar with this. But I submit that this statement may need a little more nuance. I think it is not so straightforward. It's not a very helpful term at the bedside, especially if you have patients. This is a child with dengue shock. The main problem is capillary leak. So we can see that this child is in shock, the capillary refill is prolonged, his IVCs collapse, so it's likely he's hypovolemic. But the lungs are so wet, the liver is so big, the eyes, the face is looking puffy and edematous. The lungs are wet, so is he fluid overloaded or fluid intolerant? The answer will determine your next strategy, because if you say it's fluid overloaded, because there's a lot of crackles, we need to stop fluids and maybe even diurese the patient, but the child is still in shock. So it's more likely the child is fluid intolerant, and the way to carefully, safely, gently fill it up may be much slower rates of fluids or to consider colloids. So when you look at fluid responsiveness and tolerance, fluid tolerance comes, it's in between these two. It's a continuum, and you find that while some patients, it's simple, you fill them up when they're hypovolemic and you stop when they're hypervolemic. But in some patients, they may develop fluid intolerance. So that means they need the fluid, but they're having intolerance. So this is typical in a child with capillary leak, can also occur in septic shock. Venous congestion is a unique entity, and I'm going to spend a few slides on it later. And here, intolerance occurs due to venous congestion, and fluid removal may improve organ perfusion. So it's, as I said earlier, changes with therapy are really important. We need to integrate clinical findings along with POCUS findings. So sometimes, like we said, the heart function is crucially dependent on the afterload. So a heart that is seemingly the calculated EF, a single measurement may not tell the whole story. We need to watch out for changes with any intervention. An ejection fraction of 60 would very much be considered normal, but this may be severely impaired if the patient is vasodilated because the low vascular resistance facilitates the forward flow and may mask the underlying dysfunction. So even a small dose of vasopressors in a patient with seemingly good ejection fraction may be a diagnostic clue if you're there at the bedside to assess the patient. You'll find that both the clinical signs and echo signs match well, because clinically the bounding pulses may become low volume, warm extremities may become cold, and the echo signs of a hypercontractile heart may become hypocontractile. So just monitoring the response of treatment can tell us a lot about the child's pathophysiology. So this is from an adult article, where it's a nice pictorial representation how a patient with a good baseline ejection fraction, so see the difference between the diastole and the systole, and after norepinephrine, it's come right down from 70 to 40%. So what I'm trying to emphasize to all clinicians, whether you're using echo or not, we need to do repeated serial examinations, and perhaps before and after every intervention, and reevaluate the response. So coming to the end of basic POCUS, even with basic POCUS, we can do a lot of, we can help many patients with septic shock. We can see the response. We need to look at, so we need to put the big picture together. So the child is in the center, look at the clinical parameters, urine output, cap refill, look at the POCUS, see the pressure parameters. So put all of it together and you'll know very well the child is telling you a story. Yes, I like what you're doing. So that means the heart rate will improve, and the cap refill will improve. So perfusion improves. Whereas what intervention that you've started, it's not suiting the patient. The clinical clues from all this will be very clear, and the child would say, no, I don't like what you're doing. Maybe try something else. So let's go into POCUS deep dive. And I'm going to spend most of the time on the entities in this list. So starting with diastolic dysfunction, most of the time we focus on systolic dysfunction, but diastolic dysfunction is only recently being reported in pediatric septic shock. And it's really important because the mortality may be even higher when a child has diastolic dysfunction compared to systolic dysfunction. So there's impaired relaxation of the myocardium, and it progresses to restricted filling. It's often missed because the systolic function always seems to be good. And clinically, the patient will present as persistent shock. So whether you're giving fluids or catecholamines, there'll be persistent shock with elevated filling pressures. So how does this manifest as flash pulmonary edema? When there's a lot of, a patient is typically tachycardic, has very wet lungs and persistent shock, which doesn't seem to improve no matter what inotropes or pressors are added. So as I said, this can be associated with higher mortality compared to systolic dysfunction. And it's reasonably, although most people get a little feel that is very daunting to do a tissue Doppler imaging, it's reasonably easy for a person who does POCUS regularly. And there's just two measurements that are required. So tissue Doppler will demonstrate low E prime values and a high E to E prime ratios, very reliable predictor of diastolic dysfunction, and it has less preload dependency. It's reasonably easy to do, it's simple, reproducible. So always think of diastolic dysfunction when a child is persistently tachycardic and shock doesn't seem to be getting better at all. So only two measurements are required to diagnose diastolic dysfunction. So do a regular pulse wave Doppler of the mitral valve annulus. So you have the taller, and this is a normal situation where there's a taller E wave and a smaller atrial filling wave. I really like this tissue Doppler setting for diastolic dysfunction because you just have to turn on the tissue Doppler and put your gate at the septal annulus. So this whole thing is a mitral annulus. Place your gate here and just press tissue Doppler and you get a nice waveform. So this particular wave is the E wave. So if this E wave is more than 10 millimeters, the patient doesn't have diastolic dysfunction. A good way to know is that if the myocardium is very stiff, the annulus is barely moving much at all. But if the annulus isn't very stiff, the E prime will move at least more than 10 millimeters. So people, either you do E prime alone or this ratio of the E to E prime ratios. So what about iatrogenicity? I think this may be happening more than we realize, and perhaps we need to think about it and look for it. Anything in excess, even nice drugs such as epinephrine and norepinephrine, which saves many lives, in excess, it can be poison for the heart. And a particular situation would be when a child is not getting better. Clinicians are they have this urge to give more fluid, more pressure, more inotropes, often without a clear indication. We just hope that something will help the patient, that a shock will resolve. So we tend to give more and more. And sometimes it is these agents that can cause a lot of more toxicity. And this nice paper here says catecholamines for inflammatory shocks, so septic shocks, a form of inflammatory shock, a Jekyll and Hyde conundrum. So, Jekyll, so basically it means that agents which can save lives can also kill patients. So we need to be very mindful when we give higher doses of catecholamines. It's not just large amounts of fluids that are bad for the heart, it is also higher doses of catecholamines. And maybe we should be very careful before we give doses of greater than 0.15 or 0.2 to patients. Another important entity is dynamic left ventricular outflow obstruction. So dynamic LVOTO. We need to know about it because only then we will know that we need to learn how to look for it. So this entity, we need to be prepared. The combination is typically catecholamines plus hypovolemia. You get pressor refractory hypotension. The heart is essentially slamming against itself. It's an empty heart that's slamming against itself and results in dynamic outflow obstruction. So very well described in adults, but we have found it in a few patients in our children as well. Typically, when we start diuresing them or we're putting them on renal replacement therapy and they get very negative, the blood pressure falls, then inotropes or catecholamines are started. And sometimes the patient gets a lot worse. So this is a very characteristic waveform, the VTI, do a pulse wave Doppler of the LVOTO, and the VTI has a very characteristic, this described as a sable-toothed waveform. So I'm just introducing I'm sure a few of you will already be familiar about this dynamic LVOTO. In case not, I'm just trying to introduce a concept and maybe we could try and look for it when a child is not improving despite catecholamines. So there can be a lot of similar, the management may be quite similar whether they have diastolic dysfunction, dynamic LVOTO, or catecholamines. We should try to prefer inotropes with less non-catecholamine inotropes, controlled tachycardia by whatever means you have. We need to minimize catecholamines, especially epinephrine, and balance both over and under hydration. So if it's diastolic dysfunction, they need less fluid. If it's dynamic LVOTO, we need careful filling and achieve the balance by using POCUS frequently. Moving on to right ventricular dysfunction and assessment of pulmonary artery pressures. The right ventricle is often referred to as a dark chamber or the forgotten chamber because the left ventricle takes pride of place and everyone's looking, how is the left ventricle, how's the contractility? Most people forget to look at the right ventricle. But in fact, it has particular interest in critical care because of the effects of fluid loading, particularly when the child is under mechanical ventilation. And it is estimated that about 1/4 of patients with ARDS, so 1 in 4 patients who are being ventilated for ARDS have RV dysfunction and pulmonary hypertension. Due to the ventricular interdependence, impaired RV function may lead to decreased LV output, and RV failures independently associated with mortality. So how do we pick up RV dysfunction? There are a few ways. So the easiest is to eyeball the info chamber view. And normally the RV should be about 60% of the LV. And even if it's equal in size or even larger, then we know that the RV is dilating and probably dysfunctional. Doing a TAPSE, this is a value in adults. There are age-appropriate values. But again, tissue Doppler seems to be emerging just like in diastolic dysfunction. Tissue Doppler, the tricuspid annulus. So if the ventricles are dysfunctional, the annulus moves less. So a tissue Doppler will demonstrate the S wave of less than 8 millimeters. So I really think we should work together and get normal values for children as well, because most 99% of the literature is all in adults. So another useful bit of information that we can get when we assess the shape of the right ventricular outflow tract envelope. So this is a normal shape. We can assess the RVOT Doppler envelope by a pulse wave Doppler and the parasonal short axis view. So this is a nice, smooth, normal shape, is dome shaped. As the right ventricle becomes dysfunctional, or rather as the pulmonary arterial, the precapillary. So this is precapillary as opposed to left ventricular issues. So even if there's left ventricular dysfunction, sometimes the PA pressures can go up and RV can fail. But these two, this is very specific for precapillary. So typical for a patient with ARDS or pneumonia with high PA pressures, high PVR, right? So instead of a nice dome shape, you get a short acceleration time. And then as this progresses, you'd see a notching in the RVOT envelope. So this is supposed to be a very useful sign. And in fact, this was a recent patient that we had with metapneumovirus pneumonia and very bad ARDS. So you can see here, straight down the RVOT envelope, there's no smooth dome shape, is going straight down. And you can see the notching, not captured very well in our machine, but it's definitely there. And this notching came down when we used pulmonary vasodilators, and the RV function also improved. So we can look for the echographic D sign showing when the dilated LV encroaches on the dilated RV encroaches on the left ventricle and decreases the left ventricular output. And this can sometimes be associated with a high VEXUS score, which I'm going to talk about very shortly. So if you identify a D sign, very much a decreased S waves, abnormal RVOT, and a high VEXUS score, the strategy can change completely. So even when the blood pressure is low, rather than give active fluid infusion, you can change to an active fluid offloading strategy rather than continuing to use fluid boluses. With volume removal, the dysfunctional septal shift is expected to resolve, and thus increasing the left ventricular filling and the cardiac output. So I'm just linking treatment and clinical science at all times with the POCUS so that we have a more kind of integrated global view. So whenever we find RV dysfunction, the first goal is to ensure adequate but not excessive filling. Second goal is to keep the blood pressure up. We have to keep the systolic blood pressure the higher range of normal. The third is to offload the right ventricle by measures to reduce the PVR. So all your PVR reducing strategies, including blood gas, PCO2, PO2, PEEP, nitric if available. And the fourth is to maximize the RV myocardial function by using inotropes. So it's important when we use agents such as milrinone that the blood pressure should not fall. So the first, so you can see here, inodilators inotropes come last, because it's very important to make sure the right ventricle is getting adequately perfused. So typically you can use either norepinephrine or vasopressin for this purpose. And once the blood pressure is good, you can do PVR reducing strategies and maybe inodilators, taking care that the blood pressure doesn't fall further. So RV dysfunction is very much linked to venous congestion and VEXUS, recently described in children. The focus has always been on forward flow cardiac output, the left ventricle. The venous aspect, right ventricle, has been mostly disregarded. Venous congestion or venous excess is a relatively new concept that is gaining recognition because there's a mismatch between the venous return and the cardiac output. And when venous congestion does occur, this can cause hypoperfusion organ dysfunction, especially kidney. So kidney failure is particularly the first organ to fail when you have venous congestion. Venous congestion is particularly detrimental when cardiac output is also reduced. So this, as I said earlier, we did BestFit T3. We assessed venous congestion as well, right ventricle and diastolic dysfunction and venous congestion. So we need to first look for the staghorn sign, establish that the IVC, the inferior vena cava, is dilated, and then progress and look for abnormalities in the hepatic vein, portal vein, and interlobar veins of the kidney. I find the hepatic vein the easiest. The portal veins are also not too bad, but I struggle a little bit with the interlobar, with doing the renal VEXUS. So it's a poorly recognized cause of AKI and organ dysfunction. So it's something that we should be aware of, and we can look for it. If you're monitoring a CVP, a clue may be a very high CVP in double digits, which tells you that this right ventricle has problems, and you can anticipate venous congestion. So for those of us who do not have formal cardiac output measurements, we can do this on via POCUS. We can assess the velocity time integral and calculate the cardiac output and SVRI. The cardiac VTI is gaining more prominence as the new IVC for fluid responsiveness. So really, I think what is happening in POCUS overall is that Doppler studies are coming into POCUS in a big way. So it's not just 2D, two-dimensional and M-mode, it's a lot of Doppler. So it's not too hard to get a nice VTI of the LVOTO, and that the shape of the VTI can tell you a lot of things, whether it's on the right side or the left side. The height of the peak velocity can tell you a lot. So there's lots available online. Once you get a VTI, a good VTI, how to calculate cardiac output. So I'm not going to spend too much time on that. And as I discussed earlier, what are the indirect clues that a low SVR may be the culprit? If the SVRI is low, your POCUS findings will be very similar to hypovolemia. So you'll have dry lungs, a normal, a small IVC with a very good heart function. And the only way to differentiate and decide on treatment is to determine whether the pulse pressure is narrow, where you might prefer fluid, and or it's wide, where you would give a predominant vasopressor. So if a patient has hypovolemia, it's a lovely VTI run. You'd see that their VTI is low. In adults, it's around 18 to 22 is normal. In children, it's up to about 16, which is normal. I'm not sure of the exact values. It depends on the age groups from infants to older children. So in hypovolemia, or when the cardiac output is ejection fraction is low, then the VTI may be decreased. Whereas in vasodilatation, high cardiac output, you'd find a VTI which is quite high. So it can be helpful to know if patients need fluid. Even in hyperdynamic hearts, they may need fluid. So if the VTI is low, it may be useful. Focus in the final part of my talk, focus in complex hemodynamics. So we went beyond BESFIT. BESFIT is basic echocardiography in shock therapy for fluid and inotrope titration. We did we went beyond this and did a triple tiered approach. Tier 1 was looking at, so everything that I've described is we will find familiar in this slide, because we first look for right ventricular dysfunction. We look for diastolic dysfunction, that was tier 1. We checked the SVI stroke volume index by either a non-invasive cardiac output monitor or looking at the VTI. And then finally, we looked for venous congestion. So in this cohort of patients that we treated for septic shock, so initially BESFIT, there was shock resolution in 40 or 53 patients. And we did one more BESFIT and another further 43 patients, and all improved. But we found that 8 patients had persistent shock and 2 patients had recurrent shock. So in these 3 patients, we did this tiered monitoring. So tier 1 was RV dysfunction, diastolic dysfunction, 5 each, and then looking at the SVRI and the stroke volume and venous congestion. Notably, all 10 cases with persistent or recurrent shock had greater than 1 pathology. So this can make a clinician's job quite challenging. The commonest combined pathology was a poor systolic function, LV systolic dysfunction, poor contractility with a low SVRI, so hyperdynamic circulation, low diastolic blood pressures. So if we gave anything to raise the SVRI, such as any pressors, then the heart got worse. If we gave inodilators, then the SVRI came down further. So we had to mix and match both of these, and every intervention, every dose escalation, see if the patient was better or worse. Another common combination that posed therapeutic conflict was systolic dysfunction plus diastolic dysfunction. So catecholamines are useful for systolic dysfunction, epinephrine is useful, dobutamine is useful, but in diastolic dysfunction, these can make things worse. So how do you balance it to be? So we needed to use non-catecholamine agents, focus a lot using agents like ivabradrin for tachycardia control. So it was a balancing act. So, and in our unit, although we do have ECMO, it is very expensive and most families cannot afford it. So it was nice that these 10 patients with recurrent and persistent shock, who are all considered to be ECMO candidates, we could improve outcomes in 8 out of 10. So 8 out of 10 improved and went home without ECMO. But unfortunately, 2 patients passed away and we could not save them. So putting it all together, cardiorespiratory imaging by intensivists to titrate fluid, inotropes, and septic shock. We know, especially your very enthusiastic group in Latin America, that critical care ultrasound is gathering momentum. Do not be left behind, because echo and ultrasound provides direct visualization of the heart and great vessels and lungs that no other technology allows. And this information can be integrated with other monitoring modalities. So you can provide a nice customized strategy for each patient. However, it is non-continuous, requires training, and is subjective. I worry about this part. We have a lot of trainees in our unit, and it's really important that appropriate training of all people who do ultrasound is carried out. And I was happy to hear that you all are conducting training sessions. An ultrasound probe that is carried by somebody who is undertrained and overconfident can be downright dangerous for your patient. So this concludes my my session. I've talked about basics and best fit and deep dive. And finally, thank you very much for inviting me. I hope it was useful for you. I'm going to stop sharing.
Yeah. Thanks, Dr. Ranjit, for this great masterclass. It was, in a word, it was awesome. It was great because
thank you.
This approach that with the 3 tires that you mentioned, we sometimes use it. I think that one of the main disadvantages that with intensivists use ultrasound is that they do not integrate, and sometimes just look at the systolic function and then go and use sometimes VEXUS. But this approach of your last paper was great. I must say that I have never completely read that approach of your paper, but I'm gonna copy it right now. I'm gonna copy it and put it on my on the back of my ultrasound machine. It's great. It's a great approach, and the main assertive point is that it's very integrational, very integration and bedside all the time. We use POCUS all the time as a monitoring tool. So right now, POCUS is not only an assessment tool. It's a monitor. It must be bedside all the time. I can hope in the future every patient has an ultrasound monitor bedside, just in every bed, just as we have a monitor for monitoring arterial pressure, monitoring basic vital signs. Must be an ultrasound monitor right next to the patient all the time, doing it and testing all the vital signs and everything in current time, no?
All right.
So I'm gonna ask you some questions. I don't know if the people from the auditorium, las personas que están escuchando la charla, tienen alguna pregunta para la doctora. So I'm gonna wait for them to ask some. We have in the chat, we have congratulations, marvelous and integrative masterclass from right to left without missing a detail. Thanks for sharing. This is from my friend and a member of USPed Latinoamérica, Edgar Chavez from Mexico. Wishing you the best. I think some of the questions may be in some of the parts of the presentation, and as a personal question of myself, because sometimes when using ultrasound to assess a septic shock, we have a wall. That wall is, like you said, the 99% of POCUS papers are about all those values. Sometimes I try all the time, even in my papers, even in my research, try to not extrapolate from adult values.
Right.
Which is hard sometimes because we have to determine ourselves of the values. For instance, in VEXUS, we're trying to do we make a research in VEXUS, and the first big rock was to determine the precise values for patients, precisely on the IBC, which is the main so the first part to continue the algorithm, no? So what do you think about using sometimes extrapolating from adults? So using those adult values, what do you think about?
Yeah, because the adults say that the first step is looking for a distended IVC of at least 2 centimeters, but that might be unrealistic in a small infant. So I think my colleague, Dr. Rajeshwari, is really concentrating on VEXUS. And so what we do in our unit is first do a cross-sectional and look at the IVC in relation to the aorta. So normally the IVC is about 80%, about the same size as the aorta. So if it's much larger, so it's not that exact. But if it's much smaller than the aorta, then we know that it's unlikely that there is venous congestion.
Yeah, perfect. Sometimes we use diameters indexed to somatic parameters provided by some papers from Kafuri and some others who dimension the great vessels. We have another questions in the chat that says, what place do you give the shortening fraction in the sequence?
Yep. So a good question. So it's a great way to objectively assess the function of the left ventricle. So we do a lot of eyeballing, but it's nice to have objective evidence and see if it changes after. So as I said, loading conditions can change the ejection fraction, the shortening fraction. So before and after change in loading conditions, specifically a pressor. So that might be interesting, integrated with the clinical signs and a change in shortening fraction.
Excellent. Another concern may be that in that last paper that you talk about of the 3 tires, when you talk about how the patients they improve the shock after the number 1 approach and the number 3 after the 3 approaches, really how they so do you have summarized all the interventions that you use after your final approach? For instance, I mean, you determined that the patient needed vasodilation, vasodilators, the patient needed sometimes more vasopressors and need less fluid. So in those kind of measures determine, in some patients that was similar, determine who survived the most or the least.
Let me try and understand your question. You're saying,
yeah,
which are the was the mortality highest in which group?
For instance, you have used, and 3 or 4 of those patients have a similar patterns of hemodynamics. And some of them needed one kind of therapeutic measure, and the other one did not. It was not used in one of those patients, and they have the similar approach on hemodynamics. They share the same hemodynamics and the same results, perhaps in POCUS, the same POCUS result, but receive different treatments. Those, because sometimes it's dynamics. Sometimes we use that dynamics all the time, and maybe can be subjective, as you said.
So a similar POCUS view, but different approach is what you're saying.
Yeah. If my question, so the main question will be, if in a probably further investigation or further paper that you have investigated the results not just of the monitoring, but the next treatment for those results of the POCUS approach.
I mean, I'm not really sure I understood, but I think it's very useful because different people might treat a similar POCUS image a little differently. But the simplest example is a left ventricle that is a little hypodynamic. So one colleague would like epinephrine for such a patient who is vasodilated and has decreased LV contractility, whereas another group in our own unit prefers norepinephrine. So for the same finding, we use, depending on who's on call, the child will get two different approaches.
Yeah.
So in fact, we have just concluded a pilot RCT on epi versus norepinephrine. So it was quite interesting because everybody expected patients who had poor left ventricular function to get worse when we started norepinephrine, because we thought the afterload will make the work of the left ventricle worse. But in fact, in septic shock, there are two things happening. So there's a poor LV and there's a very dilated vasculature with a low diastolic blood pressure, right? And the diastolic blood pressure is what perfuses the coronaries. So in the norepinephrine group with lower doses, there was less tachycardia. We could raise the diastolic blood pressure, and norepinephrine has a little bit of inotropin. So patients did improve, 80% improved. Whereas in the epinephrine group, the heart function improved, but there was a lot of tachycardia. And sometimes the diastolic blood pressure remained low. So they needed more therapies and they needed a little more rescue therapies. Ultimately, both groups did well, but it was a little bit more complicated adding drugs, repeated assessment in the epinephrine group, which was a little unexpected result. So we still haven't published it. It's still pilot data. It's just a small group where we were looking at the results. So I hesitate to speak any more about it, but this is something that is well described in adults. And I feel that while measurements may be different, I really feel that adult shock and pediatric septic shock are not that different, but there are different phenotypes, right? So you can have, there's a hypovolemic phenotype described in adult shock, hyperdynamic, poor LV function, poor RV function, all of which are described even in children. So, I mean, I'm not sure if I answered your question, but
I think that completely summarizes it. Yeah.
Right.
Because sometimes the bottom line of the research is just about mortality, but we know as physicians are always treating patients that not always all comes down to mortality. Those are the variables that we sometimes use that you talk about that can lead to or potentiate that final mortality. I have a final question in the chat for you, Doctor. It says, do you think we should have two echo algorithms, one for mechanical ventilation and other for the patients without positive pressure in their airway?
Yeah, that's a superb question. Very good question. So there's such a change in the cardiorespiratory interactions once they're placed on positive pressure. So that makes it even more challenging. I guess it would be helpful to have more algorithms. But yeah, so the right from the IVC, the heart function, everything might change with positive pressure ventilation. So that's an interesting concept.
Yeah, so more research is needed to determine that.
Yeah.
So once again, it was a great pleasure for us. It's your masterclass. It was so different concepts that I promise you that we're gonna talk about for days about your masterclass. We're gonna study it. I personally gonna study it right now after we close this session, because it has some interesting points, some interesting approach, and it's an excellent tool, I must say, an excellent tool, because like I said, the most excellent point is the perfect integration of the two tires, so the three. And once again, in the name of all the USPed Latinoamérica, we have Javi on the screen right now. We extend our thanks to you for participating in this session. I know it's really late right now in India.
Yeah, it's not too bad. It's only 9
Not too bad, not too bad.
Yeah.
So thanks again. We would like to share with you sometimes some of our papers and our research for you to, if you're available to discuss it and to take a look of how we're doing. So we have Javi raising his hand in the Javi, Venous. Javi.
Thank you very much. Thank you. Magnificent.